Hello friends, good evening. So welcome to yet another session of DocTutorials and RRF. This is going to be a continuation of the discussions of INI SS that we had. So this is one of the previous papers that we are discussing today. Again, as I told you, it will be areas from which the questions will come rather than the actual questions themselves. So this question is on thoracic oncology. Now NSGCT, non-seminomatous germ cell tumor, which is there in the thorax, post chemo. So this is a patient who has been treated with chemotherapy. And after that, when we look at it, the markers are normal, but there is residual disease present in the on imaging. What is going to be the next line of management? Will it be chemo second line? Will it be consolidated chemo after that with surgery? Or is it radiotherapy or is it surgery? So remember, friends, the management of NSGCT everywhere is pretty much the same. And that holds good for the mediastinal NSGCT also. So most commonly it happens in the anterior mediastinum. So overall, if you look at it, it is considered to be one of the poor prognostic side. Whenever you have a mediastinal germ cell tumor, it is considered to be one of the poor prognostic size. So the treatment will be essentially with 4 cycles of BEP or VIP. So some people prefer to use VIP because eventually these patients will need surgery in view of the lesser pulmonary toxicity. Remember, when we talk about BEP, the B or the bleomycin component can cause your pulmonary fibrosis. And because of this reason, some people will prefer to go for VIP, which is usually the salvage chemotherapy regimen, which will be used. Now, anywhere in the body, whenever you're talking about NSGCT, the CT criteria is whenever you have any CT detected march which is more than 1 centimeter in size, that is constituted to be a residue. Now, whether this residue has activity or doesn't have activity doesn't matter. So when you have a CT size of more than 1 centimeter, then you need to do surgery to resect the disease. That is the standard of care. So there is a higher chance of having viable germ cell tumor or teratomas, and there is also problem where it can transform into the somatic malignancies as far as the mediastinal NSGCTs are concerned. So any residue more than 1 centimeter in NSGCT, surgical resection will be the treatment of choice. And if you find viable tumor in this, so the management goes something like this. Whenever there are large masses, this applies to even the testicular or the retroperitoneal tumor. So retroperitoneal or mediastinal or anything is there when you have a mass. Then what is the initial treatment? It is going to be 4 cycles of BEP or VIP. Either of these will be used in the mediastinum. VIP may be preferred because of the lesser chance of pulmonary toxicity. And after that, any residue greater than 1 centimeter, then surgery needs to be done. And at the time of surgery, if you find only teratoma or if you find only necrosis, then no further treatment, no further action. Basically, you observe the patient. On the other hand, if you find any degree of viable tumor, now this viable tumor might be in the form of a viable, choriocarcinoma, it could be embryonal tumor, it could be yolk sac tumor, seminomatous elements, whatever is there, then you go for 2 cycles, 2 more additional cycles. So initially you've given 4, after that you go for 2 more cycles. In this scenario, again, it will be tip for VIP or VIP. Any of these can be used. So 2 more cycles of chemotherapy will be recommended in this kind of a scenario. Right. So then there is a question on thymus. So patient came for follow-up after thymectomy. Pathology shows thymic carcinoma B2 with perithymic fatty tissue infiltration. So it is B2 type of thymic carcinoma with a perithymic fatty tissue infiltration. What is the next line of management? Is it radiation, chemotherapy, observation, or chemoradiation? Now, whenever we talk about thymic carcinoma, generally speaking, we have to remember that the first thing is Masoka staging. Okay, so that depends on the extent of resectability of a tumor. Now, stage 1 is something where it is macroscopically and microscopically completely resected. Okay, it is a completely encapsulated, completely resected tumor. Then you have the stage 2 where you have the microscopic invasion which is present in the capsule. So there might be some microscopic residue which is left behind. Stage 2B is something where you have macroscopic invasion into the surrounding tissue. So it can be invading into the mediastinal pleura, but it is not going through and through into the mediastinal pleura or pericardium. So it is just abutting but not infiltrating through and through the pleura or the pericardium. On the other hand, if it invades the other structures, like pericardium, great vessels, lung, and all that when it happens. So then you call it as a stage 3 thymic carcinoma. So then stage 3 thymoma. Then you have in this, you look at the great vessels, aorta, IVC, SVC, brachiocephalic, all this if it is going to get involved, then it becomes a 3B status. On the other hand, if the great vessels are not involved, then it becomes a 3A. So basically, one is completely resected, microscopic and macroscopic. 2A is microscopic residue will be there because of capsular invasion. 2B is going to be invasion of pleura or pericardium or things like that, but it is not going through and through. Macroscopically, it is extending outside into the fatty tissue. Then you have, kind of like, invasion of the neighboring organs with or without great vessel involvement. If the great vessels are involved, then you call it as a stage 3A. If the great vessels are not involved, then you call it as a stage 3B. Then, of course, you have disseminated disease. So you have multiple pleural or pericardial nodules, that kind of thing when you have, then you call it as a stage 4A disease, and distant metastasis and lymphatic metastasis become a 4B disease. Now, whenever you have an R0 resection, whenever you have a thymic tumor where there is an R0 resection which is done, if it is a thymoma, no capsular invasion, and again, if it is a stage 1, basically you have a stage 1 completely resected thymoma or thymic carcinoma, then you can just do surveillance alone. That is enough. On the other hand, if it is thymoma or thymic carcinoma where there is capsular invasion which is present, so in such cases, basically putting it into 2 to 4, then we have to consider post-operative radiation therapy. Okay, so whenever it is a completely resected thymoma, so this one is a thymic carcinoma here, perithymic fatty tissue infiltration. That is the thing that you have. This type A, B, B1, B2, all this is something depending on the number of cells. So you have thymoma type A, type B. So here, whenever we talk about it, if you look at it, there is areas like, you have metaplastic thymoma, you have the B2, depending on the type of cells, whether it's epithelioid type or whether it's going to have necrosis, depending on the mitosis. So all this, so as the aggression increases, type A is the best type, basically the classic thymoma, which consists of the bland spindle-shaped epithelial cells, and there is paucity of your T cells. So that is the kind of thing that is going to be present. On the other hand, when you take up the B3, it is essentially your polygonal cells, atypical epithelial cells, which are going to be present. So all this, as the spectrum increases, you will find as it goes to B3, it is going to become more like a thymic carcinoma. But what is more important in the management is whether it is completely resected or not. So when you look at it, thymomas and thymic carcinomas, when it is an R0 resection, completely resected, stage 0, even stage 1, meaning completely resected both macroscopically and microscopically, then you just do a surveillance. On the other hand, if there is a capsular invasion, as is the case here, then you have to consider post-operative radiation therapy. And whenever there is R1 resection, any case where there is a microscopic residue which is going to be left behind, then you definitely go for post-operative RT. In case of thymoma, in case of thymic carcinoma, it will be post-operative RT plus or minus chemotherapy. And R2 means gross residue is there. Then you will go for, in both of them, whenever there is a gross residue, then it is concurrent chemo radiation. In thymoma, it is going to be optional to give chemotherapy, but in thymic carcinoma, it is going to be definitively given. So in a sense, it is the completeness of resection which will determine what is going to be the management of a thymoma or a thymic carcinoma. Anything which is R0 and stage 1, then you just observe. Okay, so R0 stage 1 Masoka stage, you just observe. When you have an R0 resection, but when it is stages 2 to 4, so completely resected, but it is, the stage is a little bit more, then you can go for RT. Okay, then you have to plan for RT. On the other hand, when you have any kind of R1 tumor, again, you will have to definitively plan for radiation therapy. And when it is an R2 disease, then you have to plan for chemo plus RT. And when you have R1 in case of a thymic carcinoma, when you have R1 in case of thymic carcinoma, you can consider giving chemotherapy also other than RT. So R0, no further therapy. R0, but stages 2 to 4, you give post-operative RT. R1, whenever it is there, minimum you give is post-operative radiation therapy. On the other hand, when it is a thymic carcinoma, you will also consider giving chemotherapy. So it becomes a plus or minus as far as the chemotherapy is going to be concerned. Whereas in case of R2 resection, in both cases, you will definitely go for RT plus chemotherapy in case of thymic carcinoma. Here it is plus or minus as far as the thymoma is going to be concerned. Okay. So that is how you will manage a patient with a thymoma. That is how you'll manage a patient with the thymoma, depending on the extent of resection that you have. Then the next question is going to be on a patient with an upper lobe non-small cell lung cancer. So with infiltration into the brachial plexus, what is going to be the next line of management? Now, this is classically the lesion where you will get your Pancoast kind of tumor. So Pancoast tumor is something that comes up repeatedly in examination. Some variety of this question will be asked. It may be brachial plexus, it may be the rib, it may be the vertebra, something like that will be mentioned. Now, remember, Pancoast by itself can be stage 3 or stage 4, depending on the structures that it is going to involve based on the staging. But in essence, whenever we have the stage 3 or this stage 4, then the initial treatment is going to be concurrent chemo radiation. So the initial treatment is going to be concurrent chemo radiation. Whenever there is a tumor which is infiltrating, whenever you have a superior sulcus tumor, the other name for this tumors will be the superior sulcus tumor. So whenever you have a tumor which is going to be your T3 invasion is present, then preoperative concurrent chemo radiation you give, and then you go for surgery, chemotherapy, and then you go for atezolizumab or osimertinib, depending on the type of molecular profile that you're going to have as far as the patient is going to be concerned. So in essence, whenever you have a T3 kind of lesion, then it is preoperative or neoadjuvant concurrent chemo radiation that will be given, and then you follow it up by surgery, and then more chemotherapy, immunotherapy, and targeted therapy. On the other hand, when you have a T4 extension, then again, if resection is possible, the same pathway is going to be followed. On the other hand, if it is unresectable, then you go for definitive concurrent chemoradiation. Now, what is the difference between this preoperative and this definitive concurrent chemoradiation? It will be the dose of RT. The dose of RT will be less as far as preoperative RT is going to be concerned. Whereas if you are going to plan for a definitive chemoradiation, here there is going to be a high dose RT which will be given. High dose RT and high dose chemo will be given as far as definitive concurrent chemoradiation is concerned. So apical tumor, so which is T3 and which is T4? T4 is going to be basically the unresectable structures, like when you have brachial plexus, when you have vertebra, and then the great vessels. Just remember what is T4. Then you all the rest will come under T3, meaning pleura, pericardium, phrenic nerve. 3 P's will come. So parietal pleura, pericardium, phrenic nerve will come. Other than that, it can be chest wall and sympathetic chain. Now, all of this we know is something which is resectable. All of this will come under the resectable criteria, where we go for pre-op, CT, RT, and then follow it up by surgery. Even in stage 4, T4 disease, when we have, still we can consider going in for a preoperative chemoradiation, because even if this vertebra, it can be resected, you can put a cage and you can replace it. Brachial plexus can be reconstructed, and the same thing applies to great vessels also. But in case it is clearly unresectable, in cases where it is clearly unresectable, then you go for a definitive chemoradiation concurrent, and then treat the patient, keep the patient on follow-up, hoping for a response. In case it is going to be definitive chemoradiation, remember, my friends, post-operatively, we have to go for this durvalumab. Post-operatively, you will have to go for durvalumab. So whenever there is a definitive chemoradiation which is going to be given, then post-operatively, durvalumab will be the drug that will be given for management of NSCLC. Right. So CT shows a peripheral lung lesion. Yeah, this was the actual question. A 65-year-old male smoker with a spiculated lesion on CT, 2.5 centimeters in the peripheral right upper lobe of the lung. There is no mediastinal nodes, no hilar nodes. What is going to be the next management? So is it going to be CT guided biopsy, EBUS, plan for surgical resection, or is it going to be a VATS guided resection? Now, in general, whenever you have a lesion, the biopsy type is going to be determined by the location of the lesion. The more central lesions are always something that will be diagnosed by your bronchoscopy. Okay, so or they will be diagnosed by your bronchoscopy and biopsy, or it can be EBUS and biopsy. So the central location of the lesions will be bronchoscopy guided or EBUS guided biopsies. On the other hand, the more peripheral the lesion is going to be, then you will plan for a CT guided biopsy. Then you will plan for a CT guided biopsy. So here the question is, what is the next line of management? Now, this is a 2.5 centimeter peripheral lesion, something like this. You can see that it is towards the periphery, right upper lobe, somewhere around 2.5 centimeters. It is lesion. Clinically, speculated everything. It looks highly suspicious of malignancy. So what you will do, there is peripheral, so there is no role of EBUS and bronchoscopy. VATS is usually assessed for the mediastinal node resection, and the initial assessment should be done by a CT guided biopsy. So the initial assessment will be done by a image CT guided biopsy. Is there a role for VATS in resection? Absolutely yes. VATS is going to be used for the definitive treatment. It's going to be used for the definitive management of these patients. So the resection will be a VATS guided resection in today's world, where you will completely resect the tumor, do a lobectomy by using your VATS therapy. So these are some questions that were asked in the previous version last year. I think it came. All these questions had come in terms of management of the thoracic tumors. Now let's go on to GI oncology. A few questions. PCI index for peritoneal metastasis in right upper quadrant. Okay, so the peritoneal metastasis in the right upper quadrant, there was a lesion. In the pelvis, there is a lesion. One lesion is 1 centimeter, other one is 2.5 centimeters. So what is going to be the peritoneal carcinomatosis index? So we all know that there is a score called as the LS size. So lesion size score is going to be there, and then you're going to go by the number of regions. So what is this LS size? So less than or equal to 0.5. Then it is 0.5 to 5 centimeters, and more than 5 centimeters, or what is known as your confluent sized nodules, which will be present. So this will be your LS1, 2, and 3. Okay, so 1, 2, and 3 is the lesion size, and 0 is there, of course, when no lesions are present. So this is your lesion size score. And what are the regions that you will have? Basically, you will divide the abdomen into 9 regions. Okay, it starts from 0 at the umbilicus, then proceeds from the right upper quadrant, epigastrium, left upper quadrant, left paracolic, left pelvic. Then you have your supraumbilical region or the hypogastric region. Then you have your right pelvic, and then you have your right paracolic region. So this is how it will go as far as the regions are concerned in the abdomen. The next thing you will have is the jejunum. So upper jejunum is going to be 9, lower jejunum is going to be 10, upper ileum is going to be 11, and lower ileum is going to be 12. So 0 to 12, totally you have 13 regions, each with a possible score from 0 to 3. So the maximum score can be 39. So this is known as the peritoneal carcinomatosis index, and this is the criteria that will be used. So the lesion size score is up to 0.5, 0.5 to 5, and then greater than 5 centimeter or a confident tumor. So this is how you will mark it. So the reason this, we already drew that, and then you have your central, right upper, epigastrium, left upper, all that is there. They may ask you depending on the particular organ which is involved also. So this is important. Sometimes they may ask you based on that. So the central, so what do you mean by the central? So anything where there is a prior laparotomy incision, the greater omentum, and the transverse colon. So greater omentum, transverse colon, and midline scar. All this will come under central. Okay. Then right upper quadrant is what? That is very simple, easy to remember. Right upper quadrant is going to be your liver and your right subdiaphragm. So right lobe of the liver, under surface of the right diaphragm, and the right retrohepatic space, all these 3. So liver, right upper quadrant, liver. So left upper 3 is again simple. So left hemidiaphragm, spleen, pancreas. Stomach will also be considered under the left upper quadrant. Remember, my friends, it will not come under the what you can say as the epigastric region. It will come under the left upper quadrant. So what comes in the epigastrium then? Epigastrium is going to be your epigastric fat pad, left lobe of the liver, my friends, and falciform and lesser omentum. So these will come in the central sector. Remember, this is some area where you can get a little confused. Then of course you have your 4 and your 7, basically. I mean, sorry, 4 and 8. 4 is going to be left flank or descending colon and the left paracolic region, right flank and ascending colon and your right paracolic region. That is very simple. Right and lower pelvis again is very simple. So in the right side, you will have the cecum appendix and the right iliac fossa. Then you have your left lower or left iliac fossa, where it is going to be the sigmoid colon. It should be there. And of course, in the pelvis will be all the central organs like your bladder, rectum, all that is going to come. Sigmoid, remember, comes in the left iliac fossa. So female genitalia, basically the tubes, the ovaries, the uterus, bladder, pouch of Douglas, and the rectosigmoid. Sigmoid is in the left side. Rectosigmoid will come in the central sector. Okay, so these are the areas or the structures that will come in each of this. They may ask you which region it belongs to. Now, if you take up this, these lesions are 1 centimeter and 2.5 centimeter. So the lesion size for both is greater than 0.5, but less than or equal to 5 centimeters. So the lesion size is 2 in 2 regions. So the answer for this, the score is 4. So the answer for this is the PCI index is going to be 4 for this particular patient. Right. Now, post chemo radiation therapy for squamous cell carcinoma of the esophagus, esophagectomy with free lymph node dissection is done. There is no residual disease. What is going to be the next line of management for this patient? Is it observation? Is it chemotherapy? Is it radiation? Or is it going to be chemo radiation therapy? Currently, my friends, remember the standard of care for the management of most of the esophageal regions is going to be your cross protocol. It's going to be your cross protocol chemo radiation. So cross protocol is going to be your paclitaxel or docetaxel and carboplatin. Okay, usually it will be docetaxel. Docetaxel with carboplatin is going to be the regimen that will be given, and along with that radiation will be given for 40 gray. Okay, so it will be given for 40 gray. So when you do this, this is going to be known as the preoperative chemo radiation. This is known as your cross protocol preoperative CTRT, concurrent chemo radiation. This is a concurrent technique. Concurrent chemo radiation is given both for adeno and squamous cell carcinomas. This technique is going to be used. Of course, when you have a lesion in the lower third of the esophagus, that is where the controversy will come. But remember, whenever you have a severe lesion type 1 and type 2, these will be treated like an esophageal adenocarcinoma, meaning preferably the treatment will be your cross protocol concurrent chemo radiation, and after that the patient will be planned for surgery. Okay, so in this particular patient you have done the surgery and there is no residual tumor. So if there is an R0 resection, margin free, margin negative resection, and if it is no residue, then the plan is to go for surveillance. Whenever there is any residue, then you have to plan for nivolumab. Whenever there is any residue, then you have to plan for nivolumab. So this is any T or any N, you have to plan for adjuvant immunotherapy using nivolumab. This is true even in the 2024 edition of your NCCN as well. Even in the 2024 edition of your this one, here again the same thing is going to be considered. So whenever you have a T0 N0, basically, sorry, YPT plus or YPN plus, whenever you have any of this, then you will plan for adjuvant nivolumab as the treatment of choice. Now, there are questions that come up on the major trials that have come. We just discussed yesterday regarding the Scorpion trial on the role of NACT in your ovarian cancer, the role of NACT in your ovarian carcinoma. Similarly, there was a recent trial about 4-5 years back only. Till recently, whenever we have hepatobiliary cancers, there was not much role of giving adjuvant chemotherapy. Though it was routinely being given, there was no evidence for it. Now, this changed with the advent of the BILCAP trial. Now, what is the BILCAP trial? It showed that there is definite benefit. Okay, so whenever you look at it, this is the capacitive group and this is the observation group. Patients who underwent resection, and after that, when you look at the curves, you can see a clear separation of the curves. So the adjusted HR is going to be 0.7. So there is a good benefit of giving. There is a good 30% improvement in survival that is there by adding capacitabine. So this trial is going to be there in primarily resected biliary tract cancers. This trial is known as your BILCAP trial. It was a multi-center phase 3 trial that came. So better relapse-free survival was established by the usage of capacitabine, and that is one trial which has been included in DeVita as well. The latest DeVita, that link is already there. So that is how we manage patients. So today there is definitive evidence. Now there are people who will go for gemcitabine as well. So can we give gemcitabine? Yes, the answer is yes. But overall, patients prefer to go for. The proof of the phase 3 trial data is that for using capacitabine based on the BILCAP trial that we have here. Okay, right. So the next question is going to be this particular clinical scenario where you have a post-Whipple's patient. Patient is on gemcitabine, comes with fatigue, dizziness, diarrhea, and floating stools. What is going to be the next step in management? Now, remember, when there are scenarios which they give clinical scenarios, there will always be a clue in your diagnosis as to what this is going to be. Now, is it gemcitabine related toxicity? Is it going to be, metastatic disease which is causing this? Is it an obstruction or an infection which is causing this? What is the reason for this? Here, the clear clue is in your floating stools. So whenever there are floating stools, it's essentially indicative of a lipase deficiency. This is indicative of a lipase deficiency. So this will come under your pancreatic enzyme insufficiency. So the next step in this management is going to be increasing the pancreatic enzyme supplementation. Instantly, my friends, just remember, usage of pancreatic enzyme supplementation post ripples is directly linked to improved survival as well. There is an improvement in survival, in overall survival data as well. So there is an improvement in overall survival data in patients who receive pancreatic enzyme supplementation. So whenever you have a patient who undergoes Whipple's procedure, just put them on those various enzymes, pancreatic flat, creon, whatever be the drug of choice that you use that, and that will help the patients have a better survival. So the classical finding that you have here is your floating stools. And again, they may have symptoms of flatulence, bloating and belching, cramping, abdominal pain. All of this is something it indicates that there is a pancreatic enzyme insufficiency. That the diagnosis is established by commonly, they may ask you how is the diagnosis established. The most commonly used test is going to be your fecal elastase test. On the other hand, the gold standard test, if they ask you, there are two ways they may ask you. What is the test which will be most commonly used? The answer is your fecal elastase test. But what is the gold standard? That is going to be your 72-hour fecal fat. What is the quantity of fat that is getting excreted without getting digested? So that is the preferable mode of diagnosing this condition. So fat malabsorption due to pancreatic enzyme efficiency is very common. Management is enzyme replacement therapy. As I already said, there is benefit in overall survival also whenever pancreatic enzyme replacement therapy is used post a Whipple's scenario. Right. So this is another question. What is the false statement regarding your giant gastric ulcer syndrome? So giant gastric ulcer, is it more than two or more than three? There are two things which are given. So one of these two is the answer. I'm sorry, I could not find a clear evidence as to which one is the one that should be preferred. More common on the lesser curve, 80% cure rate with medical therapy, and less than, you know, 3% chance of malignancy. So if you look at it, medical therapy does not usually work in a giant gastric ulcer. So some they have given us more than two, some they have given us more than three. Multiple books have tried to refer, but I couldn't find. So if anyone comes across some definitive evidence, please let me know. But anything definitely more than 2 or 3 centimeters in this scenario, that is considered to be a giant gastric ulcer. Usually common near the incisura in the lesser curve. So it's near the incisura. Highest risk of malignancy is going to be there. Risk is almost like 5 to around 5% is the risk, and they are more likely to perforate and needs gastrectomy for management. Generally speaking, whenever you have a gastric ulcer, the management is going to be usually surgical. So this holds good because of the highest risk of malignancy which is associated, especially if it is a giant gastric ulcer where the size of the ulcer is going to be more than 2 or 3 centimeters. Now they are used to asking these kind of questions with retractors and with things like this. So this one is what is known as your Thompson's retractor, which will be used in upper GI surgeries, which will be commonly used in your upper GI surgeries. So you can see that there is, one stand which will be fixed to that, what you call as the table mount, which will be fixed to the table itself. And from there, the hooks will be connected, and then flanges will be added on the side. And from there, you can use various kinds of retractors. This is used in liver surgeries. This is used in upper GI surgeries, and classically used in HIPEC. Of course, in HIPEC, you can also use something called as the Bookwalter retractor. Okay, you will use the Bookwalter retractor. So that will be something similar. Only thing is, the same kind of clamp will have a ring. So it will have a ring with serrations. That is how it will look like. So that kind of ring is known as the Bookwalter retractor. This one, what we have here is the Thompson retractor. All of this are used in similar kind of scenarios. So they may ask you surgical instruments. The easiest way to go through this is, of course, when you have used these instruments, you will know what are these very classically. No one can forget a Thompson or a Bookwater once they have seen them. But for those of you who have not been exposed to it, the simplest way is to get hold of a surgical catalog and just flip through it. So whatever things are there majorly, that you will know when you look at it, and that surgical catalog instruments will clearly tell you what are the equipment that are used currently. And of course, if you have it in your own departments, that is the best way you can handle that, right? So this is again a common question. What is D1, D2, D3 dissection and all this? Again and again, these questions have come. So this particular chart is very, very important to remember. Kindly memorize it. I already discussed it when I had a update that I did with stomach cancers. So anything, when you consider, it is for distal gastrectomy and it is for total gastrectomy, the two are similar. So 1 to 7 is your D1 nodes as far as your total gastrectomy is concerned. And as far as distal gastrectomy is concerned, it is 1 to 7 minus 2. Okay, it is 1 to 7 minus 2. This we already discussed when we were doing the class on gastric cancers, but bears repeating. So 1, then 2 is not there, 3, 4, 5, 6, 7. So it is basically the same 1 to 7, but station 2 is considered to be distant metastasis in a patient who has a distal gastric tumor. The left paracardiac region, it's very unlikely that a tumor will metastasize there. If it goes there, it is considered to be metastasis. So other than that, when you talk about your D2 dissection, it is going to be the nodes along the greater vessels. So what are those? That is going to be your celiac artery, which is going to be your station 9. Then you have your 8A, which is going to be your common hepatic artery. You can see it here. So this 7 will be your gastric. Okay. So then you have your 9, which is your celiac. 8 is going to be your hepatic artery common. So then you have your 12A, which is the anterior porta. Then you have your 11. 11 is going to be along the splenic vessels, so proximal, and then distal will come here, and 10 will come here, which will be the splenic hilum. Okay, and then you have the short gastric arteries and the distal vessels that will be there along the greater curvature. 6 and 5 is of course the supracardiac, the supra and the infrapyloric, 5 and 6. Then 3 is going to be along the lesser omentum. 1 and 2, of course, is going to be your right and left paracardiac. So this is how you will do the stations. They may show you a picture and they may ask you to identify which is the station which is going to be there. So, basically N1 nodes are going to be the perigastric nodes 1 to 6, and then you have the N2 stations, which is going to be from 7 to 12. And since why then the 7 come under the D1 dissection? Because it is the nodes along the left gastric artery, which is the primary blood supply of the stomach. That is why D1 dissection will involve the left gastric nodes. Okay, D1 will involve the left gastric artery nodes. Okay, so D1 dissection will be the left gastric artery nodes, and beyond that, whatever we have, that is going to be your, basically along the greater vessels, along the common hepatic artery, along the celiac artery. Then you have along the splenic hilum will not come. Level 10 will not come. So it will be 1 to 12 minus 2. And write it down again for the sake of easy memory. So we already saw about 1 to 7 for total and 1 to 7 minus 2. So the same thing when you take up for D2, that will be nodes. Basically, in a total gastrectomy, level 10 will also come. Just add on level 10 here. On the other hand, whenever you talk about it in terms of distal or a subtotal gastrectomy, it is 1 to 12. 1 to 12 will be there for D2 dissection in a distal subtotal gastrectomy. When we are talking about it, then it will be level 1 to 12, but it will not involve the levels 2, and it will not involve the level 10, minus 2 and minus 10. So this is your D2 dissection as far as the distal subtotal gastrectomy. So if you look at 1, 2 will not be there. So 3, 4, 5, 6, 7, 8, 9, 10 will not be there. Then 11, and then you are going to have your 12A. And again, 11D, which is going to be your distal splenic artery, that also is usually not involved because it will be close to the hilum of the spleen, where that nodes are usually not involved in the distal gastric cancer. We'll just clear the proximal splenic artery and do not do the distal splenic artery, and you will not do the splenic hilum as well. So this D2 dissections have been asked multiple times, some question with regard to this. So kindly remember this, and again, 4SA is going to be along the short gastric, SB is going to be along the left gastroepiploid, D is going to be along the distal part of the right gastroepiploid. So any of these, they may ask you the subdivisions, they may ask you 11A, 11P and 11D, or which is proximal, which is distal. Then you have your 12A and your 12B, 12 anterior periportal, or it's going to be P, which is going to be posterior. So only the anterior nodes will be removed. So like these, the variations can be asked. So remember to go through that completely, my friends. Okay. So that is the thing. And what is the absolute highest level of station? It is only the level 14. So 12 is the hilum, 12 is the perihilar things that we saw. Then we have 13, which is going to be along the middle colic, and then you have your 14, which is going to be your superior preceptive. Sorry, 13 is going to be your retropancreatic, and this one is going to be along your SMA. So these are the modes which will be present. So 13 and 14 are going to be there. 15 is going to be your middle colic artery, and 16 is going to be your para-aortic. So when we talk about D3, it will have an addition of 13 and 14. So it will be along the retropancreatic vessels, retropancreatic node, sorry, and along the superior mesenteric artery. That also when you remove, that is known as a D3 dissection. There is no role of doing a D3 dissection that has been proven in multiple Japanese trials. So currently the standard of care is to do only a D2 dissection. Till D2 dissection minimally you have to do to get a good clearance. And the evidence is there in the Dutch trial that proved that long-term gastric cancer specific survival is improved by doing a proper D2 dissection. Long-term gastric cancer survival is seen by doing a proper D2 dissection. Right. Now, features of early and late dumping syndrome. This is not really oncology, but anyway, I've put this up here. I'll probably share the PowerPoint or this one in the group. I'm just skipping this, just going on to the actual malignancy related part of things. So carcinoma of the sigmoid colon treated with surgery and chemotherapy. On follow-up, presents with liver metastasis, 2 in number. What is the next line of management? Is it chemotherapy? Is it surgery? Surgery followed by chemo, or chemotherapy followed by surgery? Now, on the face of it, what kind of scenario is this? This is after how many, this one, the months is not known. Now, initially treated, the only data that we have is, CA sigmoid. So, colectomy is done, chemo is given. This is the first treatment that has been done. So surgery and chemotherapy have been given. Now presenting with liver metastasis. Here it is mentioned as 2 in number. Beyond this, no other data is given. Now, ideally, whenever we talk about any kind of metastasis, we have to know about whether it is synchronous or metachronous. Okay, synchronous or metachronous is going to be one thing. So at the same time, or is it happening a little later? Now, whenever we have a metachronous metastasis, when a patient has been treated, then if it is a resectable tumor, then the preferred option is going to be resection. So it is always a surgery first approach whenever you have a resectable tumor. Now, why do I choose resection as the answer for this? It is just mentioned as 2 liver metastasis. Now, usually whenever we have 2 liver metastasis, it is likely to be an operable lesion. It is very highly unlikely to be an inoperable lesion. See, of course, it is possible that one of the lesions is going to be sitting on the porta or anything like that. But since nothing is mentioned, we assume that the tumor is a resectable lesion. So here, what do? Then you go for resection. Then you give anything further. So here is where the no previous chemotherapy rule comes in. So if there is no previous chemotherapy, then you plan for resection followed by capox or FOLFOX. So if there is going to be any kind of metastasis that happens, then the initial treatment, the initial treatment is going to be surgery. The initial treatment, whenever you have a resectable tumor, in terms of metastasis, is going to be surgery. The preferred first line treatment in case of any kind of metastasis, which is going to be resectable. So the question that you look for in any kind of metastasis scenario is whether it's a resectable metastasis or not, as far as colorectal cancer is concerned. If it is resectable, the first treatment is going to be surgery. And then secondly, do you give chemo or not? So chemo will be given when the answer is yes, if there is no prior chemo which is given. So what will this scenario be? Suppose you have had a stage 1 or 2 carcinoma of the colon, which is early stage disease, you may not have given adjuvant chemotherapy. So if there is no prior chemo, then now you plan for chemotherapy. On the other hand, if already chemotherapy is given, prior chemotherapy is given, then the option is only observation. If there is previous chemotherapy, then resection is preferred and then followed by observation. This is the preferred regimen. Okay. So secondarily, you can also, suppose you have got a slightly largish tumor, you're not sure regarding the resection or the margins and things like that. That is the scenario where you will consider going in for neoadjuvant chemotherapy. That is a scenario where you will consider going in for neoadjuvant chemotherapy, and then you plan for resection as the preferred modality of treatment. Right. Now, this was one question that was asked, and time and again, these questions have been coming with regard to your Bethesda criteria and your Amsterdam criteria. This, my personal feeling is the answer, one of the choices was not marked right, or the question itself was selected wrong. See, because the characteristic Amsterdam and the Bethesda criteria, when do you use it? It is a clinical criteria. Okay. So Amsterdam criteria is basically a clinical criteria to decide on when you should plan for colorectal cancer testing. Okay. So Amsterdam 1 applied only to colorectal cancers. This is basically for Lynch syndrome. Okay. This is basically for Lynch syndrome or HNPCC, whichever one you call it. So Amsterdam 1 applied only to colorectal cancers. Amsterdam 2 associated with CRC or with HNPCC associated cancers. So what are the criteria that are going to be there? So 3 to 1, that is the thing that we have to remember. 3 is 3 or more family members are affected with verified HNPCC related cancer. Okay. 1 is a first degree relative of the other two. 2 successive generations have to be affected, and 1 at least should be diagnosed before the age of 50 years, and exclusion of FA. That's all. It's a very simple criteria. So 3 to 1 is the way I will remember it. So 3 family members, okay, 3 members of the family, 2 successive generations. 2 generations have to be affected, and 1 should be less than or equal to 50 years. At least 1 cancer should be aged less than or equal to 50 years. And in this 3 family members who are affected, 1 should be a FDR, at least 1 should be a first degree relative. And definitely you have to exclude FAP, because FAP kindreds also the same kind of thing can be there. So you have to exclude an FAP. This is the criteria. So now the same thing can be applied to any of the HNPPC related cancers. So what are the cancers? We know it is for colorectal cancers. We know the second most common, which is going to be your endometrial cancer. Third most common is your gastric, stomach cancer. So these 3. Otherwise, it can be pancreas, it can be your ureter, adrenal, pelvis, upper urinary tract cancers, it can be pancreas, can be ovary, it can be the hepatobiliary pancreatic cancers. So basically you can have it in the biliary tree as well. Brain, sebaceous carcinoma it can affect, keratocontomas it can cause. So all of these are something that are known as the HNPCC related cancers. Now this is the criteria used for clinical diagnosis of a Lynch syndrome. Now when you talk about genetic testing, so that is where you will have the Bethesda guidelines that come in. So this should prompt for MSI testing of the tumors. So when will you do the MSI testing of the tumors? Now this testing, Bethesda criteria is no longer applicable. The reason is now what we need to do is something called as universal MSI testing. We have something called as universal MSI testing in all patients less than or equal to 70 years. So when the age of the patient is less than 70, meaning you can do something about it, you are considering going in for chemo and things like that, then definitely those patients require a testing. So definitely those patients are going to require testing. Those patients are going to require testing. So that is the current criteria that we have here. Okay. So currently what we need to do is any patient who has got a colorectal cancer, you have to go for universal MSI testing. You have to go for universal MSI testing. That is the rule currently. But when the Bethesda criteria is used, that was used for the time when it was not available. That was used for the time when it was not available. And then they were using the Bethesda criteria, which is similar. Basically, colorectal cancer before the age of 50 years. So either the presence of synchronous or metachronous or other related colorectal cancers. And again, age of less than 60, and then you have the MSI type of histology. What do you mean by this MSI type of histology? So here you have the sessile serrated adenoma kind of syndrome. You have the infiltration, tumor infiltrating lymphocytes which are going to be present. So those kind of thing is known as the histological pattern. So that thing is known as the histological features of MSI high when that is present. And again, one first degree relative with HNPCC related tumors, and with one of the cancers be at least one of them have the HNPCC related, which happens before the age of 50 years, and 2 or more first degree relative cancers. Okay, irrespective of the age, if there are 2 first degree relatives who have the HNPCC related, let's say one person has colorectal cancer in the family, his sister develops an endometrial cancer, then this becomes a criteria to prompt for your MSI testing according to the Bethesda criteria. So the Bethesda guidelines were used for deciding on MSI testing. Currently, it is not applicable because, as I already told you, it is universally done. Currently, it is universally applicable. Right. Next question is a 4 centimeter hepatocellular carcinoma, small pulmonary metastasis, performance status 1. What is the line of management if the child score is going to be 5? So here, child score meaning 5 when the child record score is going to be 5. So then what it essentially means, it's a child's A cirrhosis. Okay, it's a child's A cirrhosis that you are having here. So then whether you can use atezolizumab, bevacizumab, sorafenib. Now previously, whenever you have metastatic disease, the answer was straight away sorafenib. Currently, though, the choice is going to be a combination of atezolizumab and bevacizumab in patients who can withstand it. So only in child pug A, you can consider using atezolizumab plus bevacizumab as a category 1 recommendation. Other regimens are, of course, your sorafenib, lenvatinib. All these are some of the things that can be used. So we can use it again only for child's pug A, because in all these patients, we have to remember that the patients need to have a good liver function. Only then we can plan for further therapy. Right. Now, patient with a painless obstructive jaundice, imaging suspicious of a Klatskin tumor, identify the true statement. CA19 elevation is diagnostic. Diagnostic laparoscopy is a must before surgery. Distant metastases are more common. So in this, what we have to remember is CA19 has got a limited role. Though it is important when the levels are very high, we can think about it. Still, CA19 levels can be found to be less sensitive of malignancy. So it can be elevated in benign biliary tract disease as well. Can be elevated in cholangitis. So cholangitis, benign disease, all this is common. I mean, cholangitis is especially common. Cholestasis is especially common whenever you have a Klatskin tumor. So here we cannot rely on that. On the other hand, diagnostic laparoscopy should always be considered, because we know that a lot of patients will have a peritoneal disease. So a lot of patients will have a peritoneal disease, and that is the reason why we have to use your diagnostic laparoscopy in all these patients. And CEA levels will have a low predictive value for cancer and not helpful in diagnosis. So distant metastasis again are generally considered to be, when we talk about distant metastasis, what we mean by that is the presence of lung, liver, and things like that. That is less common. Liver, of course, is a part of it in many cases. It will be directly infiltrated, but other metastases are uncommon. You will find usually the loco-regional extension, which is very common, inoperable. That is going to be the one. And they may ask you about the bismuth staging. So one is going to be the common hepatic duct. So you have got your bismuth stage, which is one, which is your common hepatic duct. Two is going to be the bifurcation at the level of the common hepatic duct. Three is going to be the right. So 3A is still the right hepatic duct. 3B is going to be the left hepatic duct. Okay, so you can see the 3A and the 3B criteria. And 4 is going to be both, when both the right and left are involved. That is what it is considered. Now, previously, these were considered to be unresectable tumors. Currently, many of these tumors are done by resection, and in some cases, even by transplant as well. In some cases, they can even be transplanted. That is the way it is done. Right. Now, what is true about carcinoid? When we talk about carcinoid, multiple small bowel carcinoids are rare. Histamine is very important in the carcinoid syndrome. Alcohol aggravates the symptoms. Appendix, ileum, and rectum are the locations that are commonly seen. So here, if you look at it, which is the true statements which is asked. So multiple is rare. That is a true statement. Usually they are unifocal. As far as small bowel tumors are concerned, usually you get a unifocal tumor. In case of stomach, you will get multiple lesions. In stomach, multiple NETs are common. In stomach, it will be multiple. As far as small bowel is concerned, it is going to be rare to get a multifocal small bowel carcinoid. It will be usually a small tumor, unifocal, but with large nodes. This is the characteristic presentation, and of course, the classical desmoplastic response will be there in the nodes and can cause the pulling up of the mesentery. So all this can happen as far as the small bowel carcinoids are concerned. So carcinoid or neuroendocrine tumor, these are the most common small bowel tumors according to DeVita and according to Sebastian. The most common small bowel tumors today is going to be your carcinoid. Okay, it is the carcinoid is considered to be the most common small bowel tumors. So the origin, again, this is a question that has come up again and again, whether it is foregut, midgut, hindgut, whether it is the appendix, which is the most common, ileum, bronchus, all these have been asked. Clearly, it is given that it is the appendix which is the most common. Basically, your midgut carcinoids. It's not your foregut, it's your midgut carcinoids which are most common. And in the midgut, which involves the appendix as well, appendix, if the answer is between appendix and small bowel, I would mark the answer as appendix. Appendix is the most common site. Second most common will be your ileum. Okay, so second most common will be your ileum. Now, carcinoid syndrome is present in about 10% of all neuroendocrine tumors, where you have the bypass of the first pass metabolism. Basically, you have an elevated 5-hydroxy tryptophan, tryptamine, which uh, you know high levels of tyramine are going to be present, and alcohol will aggravate the symptoms because of the high level of tyramine which is contained in alcohol. So hepatic metastasis, whenever the liver is bypassed, when the portal vein circulation is bypassed because of the presence of multiple liver metastasis, that is the scenario when you will have the carcinoid syndrome. And again, right heart, you will have the pulmonary stenosis, which is the most common finding. This is again another question that has been asked multiple times: which valve is involved and what is the pathology? So the answer is PS. Okay. So pulmonary stenosis is the most common. This is mentioned in your substance. So these are some high yield questions that have come. Multiple questions come from carcinoid, my friends. Do read it up. That is one area. So clearing up some things is midgut carcinoids are the most common. The most common site overall is going to be your appendix. It's going to be present, followed by the small bowel. In that the ileum is going to be present. Bronchus will be somewhere around the third most common. Okay, bronchus is the third most common site. Bronchial carcinoids are common, but it is not as common as appendix and other kind of things. So falls in the management of locally advanced rectal cancer. Short course RT, long course RT, K-pox or Folfox for 12 to 15 weeks, or Folfiri. The answer is, of course, Folfiri. So Folfiri is traditionally used only in your advanced rectal cancers. So the management today, as far as the rectal cancers are concerned, is going to be something where you plan for something like a total neoadjuvant therapy. Okay, the current modality of treatment is going to be a total neoadjuvant therapy. Previously, it used to be concurrent chemoradiation, long course. So long course, where usually 50 gray of radiation will be given over a period of 5 weeks. 5 weeks and 50 gray of RT. Along with that, 6 cycles of 5FU will be given. This is known as your long course chemo radiation. Then the patient will undergo surgery. Currently, after finishing this long course, the patient undergoes K-pox or Folfox chemotherapy. Why? Because when you give your concurrent chemo radiation, usually there's going to be a waiting period. So in this waiting period, you give at least, around 4 months of chemotherapy will be, around 14 weeks of chemotherapy will be given. So that's around, roughly speaking, around 3 months. Okay, so 3 months of chemotherapy will be given, and then the patient will be taken up for surgery. Now, this number can vary, the number of months in which the chemotherapy is going to be given, but essentially, either short course radiation. So the other option of giving is your short course radiation, where 5 gray is given over a period of 5 days. Okay, 5 gray or 5 days. Now, previously, whenever you have a locally advanced rectal cancer, which means T3 and plus kind of rectal cancer is found, the treatment was short course radiation, 5 gray into 5 days, and then you operate within a week. Within a week, surgery will be done. This was option one. The option two was your long course concurrent chemo radiation. So here what will be done? This is the 50 gray over 5 weeks, usually with 6 times weekly of your 5-fluorouracil. Okay, 6 weeks of 5FU will be given. Then you will wait and then you will operate. Waiting period is around 6 to 8 weeks, and then you will operate. Now what is being done is, whenever you give short course or long course, it doesn't matter, you give that, and after that you plan for 3 to 4 cycles of K-pox or Folfox chemotherapy. And once that is completed, then you take up the patient for surgery. So basically, you're combining a combination of systemic chemotherapy plus radiation, not concurrent. It is given in a sequential fashion. Why? Because it is found that in locally advanced rectal cancer, distant mets are more common. Distant mets are the reason for failure and death. So because of this, whenever you have a rectal cancer which is locally advanced, nowadays the patients are treated by something called as TMT, or total neoadjuvant therapy, and then you operate. So this total neoadjuvant can be with short course, long course. Along with that, you go for, as I said, 12 weeks of K-pox or Folfox is given, and then the patient is taken up for surgery. This is the current protocol, which is known as your total neoadjuvant therapy. This is the treatment, it is known as your total neoadjuvant therapy. Now, there is a question on pancreatic transplant. So I'm not sure what were the options which were given, that was not discussed. So here what you do is you harvest the entire thing, SMA, SMV, the segment of duodenum. So when you harvest it with the duodenum in place, then basically you're avoiding the pancreatic anastomosis. This is from the donor side itself. The pancreas with the duodenum is going to be harvested. So it can be sutured either to the stomach. It can be sutured either to the stomach, or it can be sutured to the small intestine. It can be sutured in the area where it is normally done. Either of these two will be done. So two ways it can be done is, one is a simultaneous kidney with pancreas, which is the most common type which will be done. Simultaneous kidney and pancreas, that is the most common type which will be done. Or otherwise it can be pancreas after kidney transplant. So when the initially the renal transplant is done, and after that pancreas transplant is done, and rarely pancreatic transplant alone. Pancreatic transplant alone can be done. Now, where is the scenario usually will use it? This is in a patient with a diabetic nephropathy. Okay, so patient with long-standing diabetic with a diabetic nephropathy will be the common scenario. That is why usually the kidneys will be transplanted along with the pancreas or in a sequential fashion. Rarely you can use the pancreas transplant alone when you have a very good renal function of 70 to 80 ml. When it is around 50 ml, then you will do the, when the low GFR is initially there, then you will transplant, make sure it gets raised, and then after that you can do the pancreatic transplant alone. So the risk of graft failure is calculated. Implantation can be done in the right iliac fossa. Y graft will be used in the donor. So donor, this is the sequence. So donor's external iliac is to the splenic donor, internal iliac to the SMA, then anastomose to the common iliac in the recipient. So the common iliac artery in the recipient is where it will be used for the anastomosis, and the portal vein will be done to the superior mesenteric vein to the portal circulation and to the distal IVC. So this is the way. You have both the portal drainage and the systemic drainage. You have both the portal drainage and the systemic drainage which will happen. And duodenum to enteric transplant, this is the most common thing which will be done. 80% of cases are duodenum is transplanted to the, sutured to the enteric surface. Rarely you can use duodenum to, cystotomy can be done. That is done only in 20%. So this is the way a pancreatic transplant will be done today, right? So then we have absolute contraindication for a live donor liver transplant. Is it residual volume of donor less than 30, steatosis, or age less than 50 years? Now, maybe the answer is all except, because when you look at the criteria, age less than 5 years is definitely a contraindication, and an FLR in the donor less than 30 is also a contraindication. So whenever we do transplant in a live donor setting, so you have to find out that when there is insufficient liver volume or vascular or biliary variations that will preclude a safe liver resection. The first point is the donor should be safe. The first point whenever you do any kind of transplant is the donor should be safe. So at least many centers will have a cutoff even less, they will have a even smaller cutoff of having probably around 35 to 40%, but the least value that I could find was 30%. So at least the 30% cutoff is needed for them to make sure. So this is mentioned in your substance. So 30% of FLR of donor should be there. Obesity, gross obesity, when it is there, that may lead to a poor already a steatotic liver in the donor. So whenever there is a BMI which is more than 35, that is again another contraindication. The same way, presence of severe disease like coronary artery disease, CVA, uncontrolled diabetes and hypertension, all these are contraindications. And any patient with psychosocial problems is also an absolute contraindication for being a donor, basically. Okay, so again, age as a criteria, age less than 18 and greater than 45, and any type of liver disease is also going to be absolute contraindication for a live donor liver transplant. So today's class, we will close with this, my friend. Tomorrow again, we are going to have a session where we'll continue this and we'll finish up the rest of GI and the other types of oncology as well. Now, remember, these are questions from areas that come commonly. Again, I'm stressing on that. That is why I put up these questions and highlighted some important points which are there here. I will try to share the PowerPoint so that you can have access to it just before you go for the exams. Thank you, my friends.